Major General Professor Tejinder Singh Aluwala to come over the dais and to take the responsibility to give the concluding address of this particular session. Major General Professor Tejinder Singh Aluwala is the head of the Department of Ophthalmology of Institute of Medical Science, Jaipur. The other members are yet to join. They are on the way. Professor B.N.R. Subuddhi, our past president. A few of our speakers are absent. That's why if anybody else are interested to give their presentation, they are all welcome. Now we like to honor our national president with the medallion, then we'll proceed with the session.
तो फोटो तक खिंचवा दो। हाँ खिंचवा आ गया आ गया आ गया।
Thank you very much. Now, we like to pay our sincere regards and acknowledgement to the local organizing committee as well as the scientific committee of All India Ophthalmological Society to provide ACOIN 2 sessions today and tomorrow to discuss the theme of our session, which has been suggested by our national president and will be echoed nationwide, reach the unreached. Please be kind to allow me to go with the preamble. The suggested ways for ideal positive eye health care awareness amongst Indian by ACOIN. At the beginning, I request all of you to stand for 30 minutes to pay our condolence to the great community ophthalmologist of India, nobody else than Dr. B.K. Jain. Dr. B.K. Jain, the architect of Indian community ophthalmology, architect of Sadhguru Netra Chikitsalaya, Chitrakoot, who has recently passed away. And he is a great ACOINian, and he always Om Shanti. ये क्या हो? National Program for Control of Blindness was launched in India in the year 1976, and the slogan was Eye Clinic at Your Door, and our mission was to reach the unreached population. Once again, we like to recall and rejuvenate ourselves with that particular slogan, "Eye Clinic at your door," and ACOIN is determined to reach the unreached population. Here is ACOIN with the aim of sight for all, with a beautiful sight like lotus amongst the community who are living in unreached areas within the small hearts. We always believe with the mantra of Swami Vivekananda, Uttishtito Jagrato Prappo Varannito, arise, awake, attain. Don't stop until you succeed. The goal of ACOIN is advocacy in community eye health care around Indian subcontinent. That's why we are organizing annual conferences. We are instituting ACOIN hours to motivate. We are holding international assemblies, BGT sessions to prepare opthal generation next, community eye health surveys in unreached areas, felicitation, and overall our journal. We have to break the barrier of the wall of ignorance amongst the population who are still unaware of the community eye health care services in their vicinity. That's why we are going on with our Drishti Ratha Yatra, and so far we have traveled 140 districts of India with our Drishti Ratha Yatra. And it was started in West Bengal in 2018 and going on in different districts. With all these activities, ACOIN is going to celebrate its Silver Jubilee this year from 24th to 27th September in Kolkata. We call each one of you to join this session. We're all happy to announce that His Excellency, the immediate first President of the Republic of India, Sri Ramnath Kovind, have confirmed his participation to inaugurate our Silver Jubilee celebration in Kolkata on 26th of September at 3 p.m. And we have assured him that we will keep no stone unturned to assemble at least 2 ophthalmologists from each of the districts of Indian subcontinent. So it is our duty of each and every ACOINian to motivate at least 2 ophthalmologists from each of the districts of Indian subcontinent, India, Bangladesh, Nepal, Sri Lanka, Bhutan, everywhere, to assemble before him to encourage about our activities and to materialize our goal, advocacy in community eye health services in Indian subcontinent. With all these words, I like to call upon Dr. Shatangshu Mathur, our dynamic chairman, scientific committee, to give away his introductory address. Thank you very much.
Good afternoon. Good afternoon, everyone. Respected chairperson, distinguished guests, and my dear colleagues. It is my privilege to introduce the session that Community Ophthalmology Reaching the Unreached. Blindness and visual impairment remain major public health challenges worldwide. According to global estimate, more than 2 billion people suffer from
SMS में माया हाड़ा coordinator of this.
suffer from vision impairment, and a significant proportion of this is avoidable or treatable. In countries like India and other poor countries, diabetic retinopathy, cataract, and refractive errors still remain undiagnosed simply because they don't have access to timely eye care services. The biggest challenge is not always a lack of treatment, but the gap between the available services and the people who need them most. Community ophthalmology attempt to bridge this gap. It emphasized taking eye care beyond hospitals, as Dada has said, through outreach camp, mobile eye units, where Dada is already taking Rath Yatras all over India, school screening program, tele-ophthalmology, and public awareness initiatives. These efforts help identify patients early, provide timely treatment, and most importantly, prevent avoidable blindness. The concept of reaching the unreached reminds us of our responsibility as ophthalmologists, not only to treat patients who come to us, but also to reach those who cannot come to us. Today's session will focus on practical experience, innovative approaches, and strategies that can help strengthening community eye care program and improve accessibility of service to undeserved under population who are not able to reach us. I am sure the insights shared in this session will inspire us to expand our vision of eye care from hospital-based treatment to community-based prevention and services. Thank you very much. And we welcome you all in this session. And tomorrow again we have a ACOIN session. And we request you all to attend the Silver Jubilee celebration of ACOIN in Kolkata.
क्या करना है? Number 3.
So, thank you, Satanshu sir. Now we have a focus talk with Dr. Awadh Dubey, and yeah, he's the president of ACOIN. Yes.
Thank you very much. It indeed is a great privilege and honor that I have been bestowed upon
Introduction, किसको introduce करना है?
the
Session को
very
introduce कर दिया?
important assignment that is to be the leader for this year. Dear friends,
Introduction of the session समझा मैंने?
as we all know, the science is progressing very fast, but at the same time there is so much of destruction around the globe these days that what is more important for all of us to understand the gravity of whatever services we can give to our fellow countrymen, especially on the problems of the eyes. So with these words, what is more important for all of us to take care of the, and you know, dear friends, we have come across many times this type of situation in the patients who come to us, that we feel that helpless, that we cannot do anything for a woman like this. And sometimes if you close your eyes for a minute, we all understand that what happens to those patients. Similarly, what is my feeling, and also when I was given the charge of this, I request all of you to focus on country first, and whatever are the problems, how we can solve them, how we can reduce them. And for this, what is more important is that if we have a comprehensive approach, which is all possible for all of us. And that's why when I was requested to take the charge, so then I thought that nothing could be better than if we focus as to reach the unreached. If we go into the villages, if we go into the remote areas, we find that small problems lead to almost blindness. And here comes the dreams of our Dr. Samanta. He has put the entire life for this, and let us give a big hand to him. because Dr. Samanta is an example that out of the glamorous this whole program which is going on in this whole premises, but how many of us could take out little time to discuss how we can reduce the problems of our fellow countrymen. So this is what definitely should give us more encouragement that at least we dared, we thought, and we are here to do anything which is possible for us. These are those causes where the small problems become a big problem, and then most of those people, they lose their eyesight. And our focus through this program, there are still 5 months before the annual program is to be coming, and we are designing some of the activities for all of you, where we would be taking care of how we approach, how we can treat the patients in a better way, and then the whole thing will be also given some of the awards and recognition in the presence of our Honorable 14th President of India, Shri Ramnath Kovind ji. So we should gear up for this, and gearing up of this is important, and this is what is my call to all of you, that every one of you should feel that you are the president, because the president is just a name, but it's the spirit of all the ACOINians together. I would call, and I would say that that is what is more important. So how we can proceed further if we give little time, say every week, 2 hours or something, and also how we can reach the unreached, and then you will find that what more can be done. And it's such a wonderful program which Dr. Samanta has designed for us: campaigns, rallies, Rath Yatras, and all these ways touch the heart of the people whosoever see these. The surgical camps, the school screenings, and all these. Besides that, how much we can do for the awareness part, that also is an important thing. So my responsibility is not my own. It is all of you who are present here, and those who have not come. We will be going to write to you to appeal to all of you that how we can be of helpful to the fellow Indians. And so many presidential awards would be done this time at the state level, at the city level, and also at the individual level. The performance, and also the one thing which is more important for all of us to understand, that the membership growth is the key to success. And wherever we are, if we can include some of the new members, that would be a big, very big victory for all of us, whether it is research, community service, or even the papers to be present by the PG students. Dada has already spoken about the great visionary, and then who has very rightly said that we should not stop till the goal is reached. So in these 5 months, whatever we can do, and that is what is the strength. I alone cannot do anything, but together our strength would be multiplied. So dear friends, with these words, and also thanking Dada for initiating so much of strength within us that we can really prove to the entire world. And I'm just ending this with a song, but then I don't think this song can be played for some reasons. But dear friends, just look at this picture. What is the message of this picture? When I operated this man who both eyes were cataracts and he couldn't improve, and once he got the relief, he said to me that I am very thankful to you. But my mother, when I passed and became an ophthalmologist, my mother used to say that it's not that he should thank you. You should be thankful that he had the courage also to depend on your quality of work so that he got the eyesight again. So always remember, in our practice so many times, many this type of situations will come in your life, and this is the best photo for my life. So thank you so much for this. There is a lot to be seen, but I think it is, without saying more words, I'll try to put actions into my tenure, and whatever best is possible we'll do. Thank you so much.
Thank you, sir. And it's always so inspiring to hear from you. Your speeches are always so motivational. And for everyone's information, sir is known for his dedicated community services and outreach programs, and have conducted more than 3 lakh free surgeries, and is known for conducting eye camps in so many states. So it's an honor to hear from you, sir. Yeah. So that was the focus talk by Dr. Awad Dubey, and there is a little change in the order of the talks here, and I'll request Dr. Purvi Bhagat ma'am, and she is a professor at MNJ Institute, Ahmedabad, and well known for her involvement in various societies like MICS and WAS, and as well as the ACOIN. So ma'am will be speaking on screening, key to preventing glaucoma blindness.
Thank you, Dr. Maya, and thank you, Samantha sir, for including this presentation and inviting me for this session. So I'll be talking on glaucoma screening, which is actually the key to preventing blindness from glaucoma. So what is the silent burden of glaucoma in India? As per the current data, about 12 million are affected in India from glaucoma, out of which 1.2 million are actually blind because of glaucoma. And glaucoma contributes to about 11 to 13% of the total blindness that exists in the country. And an unfortunate fact is that 90% of the affected people are actually unaware and still undiagnosed that they have this disease. So there is a large undiagnosed burden of this disease in the country, and there is a definite need for screening. So why screening matters? One, there is a general low awareness about the disease. The disease itself is asymptomatic in the early stages. There is limited access to specialized diagnostics like perimeters and imaging techniques. And overall, there is a poor health-seeking behavior in the country. So in one of our studies and campaigns, we screened all our paramedical and non-medical staff at our center. All the optometrists, the housekeeping staff, nursing staff, security people, and all the office and administrative staff. And this study has actually been published in this Indian Journal of Community Ophthalmology also. So 403 total employees were actually invited for screening at our clinic, out of which unfortunately only 216 came to us and were screened. So they could not turn up either because of, again, lack of motivation, work responsibilities, time management issues. And the assessments we did were basically a thorough history taking for any risk factor assessment, visual acuity, slit lamp, IOP by the Goldman, central fundus, and gonioscopy. All the suspects were then subjected to a complete, thorough, detailed glaucoma evaluation. All glaucoma patients were managed appropriately and counseled, and a general education about the disease and the risk factors was given to all. So surprisingly, out of all those that were screened, about 26 males and 39 females actually had a positive family history of glaucoma. In about 6, there was primary open angle glaucoma which was diagnosed, and 13 had actually primary angle closure disease. And in the PACD, again, 2 had primary angle closure glaucoma, 3 had primary angle closure, and 8 were primary angle closure suspects. In another campaign, we screened in 4 old age homes and 1 senior citizen club in and around Ahmedabad. This also we have published in an international journal. Again, we similarly assessed all those elderly people for risk factors, vision. We could not take the slit lamps at all places, so we did a torchlight examination. IOP was done by the Eye Care 200 and a central fundus examination. And again, the suspects or those who were found to have glaucoma were referred to our center for detailed management and evaluation and management. And similarly, like the earlier one, management and counseling of patients who were diagnosed to have glaucoma and a general education about the disease to everybody was given. We screened about 205 elderly people, out of which family history was positive in the first degree relatives in 6. The elderly people who had to be referred for further evaluation were 123, out of which 64 had to be referred for glaucoma evaluation. Unfortunately, out of those 123, only 22 consulted our center because they were in old age homes in the periphery, there were mobility issues, they were not motivated, they had other comorbidities. Out of these 6 were actually suspects: ocular hypertension in 6, primary open angle glaucoma in 2, secondary open angle in 1, and 1 elderly person actually had a trap, but there was total loss of follow-up in 1 person. So from these all different activities, our key observations have been that elderly people, they are actually at a very high risk for glaucoma, but they have significant different additional challenges like their own comorbidities, lack of motivation, compliance issues, mobility issues, dependence, financial constraints, etc. Even healthcare employees, the people who work in healthcare setups, they do not themselves undergo screening despite having risk factors. Therefore, job profiles do not necessarily translate into health awareness, health education, and preventive behavior. And therefore, awareness is still very, very low compared to what we expect. So, opportunistic screening should definitely be done, either hospital-based screening of relatives of glaucoma patients who come to clinics, as World Glaucoma activities that are currently going on, community camps, or integration with other general health checkups. Because it definitely identifies undiagnosed glaucoma. It is very feasible, scalable, and cost effective. And along with actual screening of the condition and early diagnosis, it is also an opportunity to educate people and improve the community awareness. Thank you.
Thank you so much, ma'am, because this is one condition which definitely need awareness at community level because that is a cause of preventable blindness. Yeah, Dr. Aluwalia would like to say something.
Yeah, very nice presentation, ma'am. The only thing is, as of now, in general population, screening is actually not feasible because if you take that numbers needed to treat, that becomes difficult. But like what you have done, say in old age homes, in people who are actually more likely to have glaucoma, there the positive cases are much better. And especially the captive audience, all those coming to the OPD, even those coming for routine checkup, I think we must screen those. And in the morning today, I had attended a session where in Australia they have carried out a very big study where they are they made a genome with which they are saying with those tests, which is now commercially it's going to come out, that blood test will predict that which patients are likely to develop glaucoma and progress fast, which are likely to develop glaucoma and then progress gradually, and which are the ones who do not need screening at all. This is all in the future, but once it comes, I think that will be also a big help. A very nice talk. Thank you.
Dr. Purvi, in fact, it was a wonderful presentation, but you have studied a very identified population, isn't it? You are a very popular glaucoma specialist. I know you are getting a lot of referrals from all over and most of the states around Gujarat. So, how do you feel about this scenario of this problem in overall country's prospect?
So overall, sir, as shown from this one small incident, like locally in and around the city of Ahmedabad, if this is so, it is going to be a similar condition whether we consider the state or whether we consider the country. So the idea is basically to bring out this need to do the opportunistic screening. So like wherever, whenever possible, in whatever way, even if it's a small outreach program, like we just screened 4 old age homes and 1 senior citizen club. So gradually, if that can be picked up and it can be made in a more nationwide type of a campaign, and especially in weeks like this where everybody is working towards glaucoma week activities and doing awareness programs. so that gradually maybe over time it can help to bring out some change. Yes, sir.
Hello. It was really a good presentation, and as I was thinking about how, with our own excellence in our own field, how we can contribute to the ACOIN, because that is very important. And I always believe that youth is the key to the country. So please think about this, and maybe some of the surveys, whichever you do, I'll talk to you after this, and we can still we have 5 months, and then how it can continue, not on a larger scale. Thank you so much.
Thank you,
so much.
ma'am.
Actually,
So-
probably another thing coming in is AI and teleophthalmology. No, but there are apps available which can actually, uh, from the fundus picture of the optic disc itself, which can give you an idea which patients need referral and which don't. So I think in the future these things will help a lot in screening and getting positive patients.
So more than what tools are actually needed for screening, it is whom to screen and when to screen. Because unless the people are not going to come to us, so we have to take the tools to them and then see
Like what we are
can
doing
be
for
done.
diabetic retinopathy,
Yes.
something like that. Along with that, we can.
Simultaneously.
Since you were talking about the campaign, what activities had been carried out at your center as we are celebrating National World Glaucoma Week?
Actually, we initially did the screening of the people who are working at our center. Then we did the old age homes. So this entire week through, actually it started last week only and will be continuing next week also, because currently I am here. So we are doing screening of all the paramedical and non-medical staff of the entire BJ Medical College. So all, yeah. So similar but on a larger scale. So gradually we are going step by step. So everybody, all other than the faculty, all the supportive staff, administrative staff, all the household, housing people and everybody, we are doing their screening. And along with that, we are doing educational sessions like taking small counseling sessions in the morning and making them aware of if you have a history, you should get your scalp screen and all those risk factor education and all that.
As our president sir has suggested, now take it up to the
Yes,
community
yes.
level.
So from our institute, we have gone to the college. From the college, maybe we will
That's
grow
Thank you.
larger.
Thank you.
Okay, thank you, sir, and thank you, ma'am, for that wonderful discussion. So, our next speaker is Dr. Chandana Chakrabarti, ma'am, and she has been a former HOD at RIO and Medical College, Calcutta, and she is a renowned oculoplastic surgeon, and she'll be speaking on orbital cysticercosis, a challenger for ophthalmologists. And before that, I'll please call upon Professor Tariq Qureshi, sir. He is past president of ACOIN, and I'd request sir to please join upon the dais.
Good afternoon, everyone. Thank you, Dr. Samantha and the entire team of ACOIN organizing committee and the team of AIOC for giving me the opportunity to talk in this session. I'll be talking on orbital cysticercosis, a challenger for ophthalmologists, neuro-ophthalmologists, and general practitioners. Ocular cysticercosis is a parasitic infection caused by Cysticerca cellulosae, a larval form of the pork tapeworm Taenia solium. It is recognized as a major health issue worldwide by WHO. It can cause blindness, but this is a preventable cause of blindness. The disease is endemic in Asia, Africa, South and Central America, Eastern Europe, and India. The various mode of infections are through contaminated food and drinks, fingers of infected person, internal auto-inoculation by reverse peristalsis. These are more commonly seen in children because of their unhygienic habits. I'm not going to the life cycle of the this is the pig is the definitive host and human is the intermediate host. The sites of predilection in human bodies are the CNS, neurocysticercosis, subcutaneous tissue, skeletal muscle, heart muscle, eye, and adnexa. In eye, the posterior segment, that is the subretinal and intravitreal, is the most commonly seen, that is 68%. Subconjunctival space 20%. Anterior segment is 8%, and eyelid and orbit 1 to 4% as per various literatures. Let us come to a case scenario. 7-year male who came with after getting treatment as orbital cellulitis outside, but there was partial resolution of the disease. So when he was brought to us, then there was a firm ill-defined non-pulsatile mass with mild tenderness in the suprarenal quadrant of the left eye with restricted ocular motility. As you can see that there is in the hypoechoic area in the USG B scan, and in the CT you can see there is an well-defined hypodense area, and along with the medial ductus enlargement and thickening. So we diagnosed it as a case of myosarcosis on left medial ductus and treated with the oral steroid albendazole, and the child gradually, we tapered the oral steroid gradually, the patient was fine. This is another patient, a veterinary surgeon who came with the, this type of orbital cellulitis picture. Again, the picture is almost same as orbital cellulitis. So many times we actually misdiagnose. This is, as you can see, this is a typical picture of dot in the halo sign. We treated the patient in similar way, and the patient was fine after 2 months. The usual clinical features of this myosisticercosis of the orbit are starting from the orbital cellulitis. The patient can come periocular swelling, ptosis, proptosis, restricted EOM, diplopia, dimness of the vision, because sometimes it can involve the optic nerve also, either by the sheath of the optic nerve, or there may be compression by the adjacent tissues. Or sometimes you can see a spontaneous extrusion also. This type of scenario, like a Calazian also, the patient can come in case of eyelid cysticercosis. Brain tissue cysticercosis is rare with ocular cysticercosis. The left eye is more commonly involved. The diagnosis is basically a clinical and on the image dependent. Tissue diagnosis is not essential for initiating that management. Serial B scan, serial CT scan will help in which stage the cyst is and the disease is. CT scan of the brain is essential, as because before starting the cysticidal drug, you have to do it, as there is always a chance of anaphylactic reaction as you start the drug. So you have to always admit the patient and start the treatment. Medical therapy is the main way of treatment. Albendazole 15 milligram per kg in divided doses in twice, and oral steroid in tapering doses 1 milligram per kg body weight. And then this sometimes usually you have to continue it at 2 months, but sometimes you may have to continue it for more than that. Surgical removal is rarely needed. In subconjunctival cysticercosis or eyelid cysticercosis, you may need it. Some more cases I'm not going in detail. This is the case of involvement of patient came with the ptosis. Another patient who came with the ptosis, you can see the cysticercus both in the USG and the CT picture. Differential diagnosis may be such type of cases: epidermoid, cyst, dermoid, Calazian. In case of tubercular foci can come in the similar lesion in case of neurocysticercosis, which is a resolved lesion. Orbital myosisticercosis, this can, other orbital myositis can be misdiagnosed. So you have to be very cautious what you are actually dealing, whether it is a case of IOID or an orbital myosisticercosis. Multi-specialty involvement is needed to treat such a case. And it is important to be aware of the varied clinical presentation of this parasite to prevent the sight-threatening and life-threatening complication. Judicious use of oral steroid and anti-parasitic agent help in remission of the cyst, and it is the mainstay of the treatment. These are my references. Thank you.
Thank you, ma'am, for an excellent presentation. We should really keep such diagnosis in mind while dealing such cases. Luckily, for the sake of the knowledge of the audience, I may tell that the coordinator of this program, Professor Maya Hada from SMS Medical College, Jaipur, is also a national reputed oculoplastic surgeon. I would request her to share her views about the presentation and her personal experience, if she has, about any such cases.
Yes, thank you, sir, and thank you for your kind words. And definitely, being endemic for parasitic cyst, we should have a high index of suspicion for all such conditions, especially cystic circus, which usually presents as orbital cellulitis many a times. And as you have shown so many cases of ptosis, so usually they are not treated as cystic circus, and many a times the diagnosis is missed. So recently, I had a case when there was a lacrimal gland cyst, and then it presented as dacryoadenitis, and he was treated with antibiotics and not resolving, and there was no scolex. The cystic lesion was there. So sometimes the scolex is not there, and you have to have a clinical suspicion, and on the basis of that, I started on this thing, steroids along with the albendazole. So that is also important, that if you don't start steroids and you just give albendazole, then also it will not help in the clinical resolution. So that is very important, and you have to continue the steroids beyond albendazole. So these are the few points that...
In one of our case, I had to continue it for 4 months, actually, the steroid.
Yes. Usually 6 to 8 weeks. Yes.
Thank you.
Thank you, ma'am. Yes. So for the next talk, okay, Dr. Urmil is here. Ma'am, can we just request, because Dr. BNR has come, you need, okay, ma'am. Can we take? Okay. So, yeah. So Professor Dr. Urmil Chawra from PGI Rohtak is here with us, and she'll be speaking on periocular dog bite injuries. And we have Dr. BNR Subudhi sir with us as chairperson. And are there enough chairs? Okay.
Good afternoon, everybody.
I request sir to join us on the chair.
Thank ACOIN for giving me the opportunity. And I'm going to speak on a very common topic which we often face day to day in our community areas all around our residences. Now it's become so frequent. So periocular dog bite injuries, which has become a community health menace. WHO in January 2025 stated that globally up to 10 million annual injuries occur by dog bite. Low and middle income countries are more inclined, and around 76 to 94% of all animal bite injuries occur by dog bite. And more than 50% animal injuries while traveling are by dog bite. And periocular injuries constitute nearly 10 to 15% of all animal bite trauma. So with this census in mind, we can imagine how common it has become. And the Ministry of Health and Family Welfare also reported that incidents of dog bite in India have seen a 26.5% year-on-year increase from 2.18 million incidents in 22 to 2.75 million incidents in 23. Kerala, Jharkhand, Delhi, Assam, Chandigarh, they have seen the highest increase. And the average rate of sterilization is very low as compared to this. Young age is obviously risk factor in the sense that children are found often playing in the streets, or they go out for in the outside areas, their residences, and they become a victim of these things. Male sex, attention deficit hyperactivity disorder patients, and injured and ill dogs are also threatening in such cases. Soft tissue infection rates after dog bite injuries to head and neck are less than 5% due to the rich vascular supply to the area. However, this rich vascular blood supply only becomes a problem because it may predispose to catastrophic blood-borne infections due to valveless venous supply to the face, which communicates with the skull base. Common organisms include Pasteurella, Streptococcus, Staph, Moraxella, and Lachman has classified these dog bite injuries into stage 1, 2, 3, 4A and 4B according to the depth of involvement, starting from superficial to the last stage, that is stage 3, where bone and organ damage may be there. Rabies, as you know, is a consequence of the dog bite. It is an acute viral disease of CNS caused by type 1 Lissa virus. 100% fatality rate is there, mostly due to low coverage of vaccine and lack of proper treatment, it has been found. And infiltration of wound with human rabies immunoglobulin is recommended, followed by vaccination is also required. Now, as ophthalmologists, what problems do we face with these dog bite injuries? Generally, the injuries in this periorbital area are confined to the eyelids, which may be a lid laceration, a rupture, or an avulsion, or it may lead to a tissue loss. Lacrimal system being in that area is also often more prone to injury than other parts. The canalicular tears are often seen, with avulsion of lacrimal gland can also be there. Conjunctival laceration, subconjunctival hemorrhages, and chemosis. And globe involvement may be there, where open globe injuries like corneal tear or scleral tears are often also seen. So I am just restricting to the dog bite incidences where orbit may be the involved area. Basically, how we manage it, we stabilize the patient first. The basic triage has to be done. Assess the mechanism of injury, and once you are sure that it is a dog bite injury, we need to proceed. We observe the ocular adnexa, basic examination, anterior segment, pupillary examination, all should be done. Location of the bite, overall health condition of the bitten person, and try to find out whether the dog is vaccinated. If it's a stray dog, nobody can tell you about the vaccination status. And it is recommended, if it is a dog which is a pet dog, it is recommended to confine the dog and observe daily for 10 days under the supervision of a veterinary doctor and in coordination with the local public health authorities. Main principles of care include early medical management, irrigation and cleansing of the wound for at least 15 minutes with soap and water. Primary closure if the risk of infection seems low and it is a very superficial injury. Prophylactic antibiotics, rabies post-exposure treatment, and administration of tetanus vaccine. So ideal virucidal agent is povidone iodine, which should be definitely used after soap water cleaning. We can use the syringe and 18 gauge catheter to create a forceful stream and flush the entire area. 150 ml it is recommended should be used, and thorough cleaning and debridement of the area should be done. Then we have these basic things in mind like pain management, antibiotic, tetanus and rabies prophylaxis is very important. Should be kept in mind. We have this data which has been provided by the Government of India, where it's a minor wound, only tetanus toxoid, or we add it with the immunoglobulin. Protection level should be achieved by day 14 of a post-exposure regimen. Okay. With or without simultaneous administration. Then again, depending on the category of wound, vaccination and immunoglobulin has to be considered. 0, 3, 7 and 28 days we should keep in mind whenever there is any such exposure. These are not very expensive vaccines or immunoglobulins, so one can afford them, and government hospitals have them in free supply also, so it should be taken care of. When it comes to lid injury, it can present in various forms. It can be a full thickness lid tear, it can involve the punctum, medial canthal area. So we have to, and after even you have treated, you've done the needful, there can be long-term complications of periorbital scars or cicatricial ectropion which need to be dealt secondarily. I won't go into the very much detail, but lacrimal trauma is very common in dog bite injuries, and it's generally seen in young age. Lower canaliculus involvement has been found to be common. It can be due to other causes, but dog bite is one of the commonest. And when it is there, copious irrigation of wound area should be done. And for prophylaxis, we need to give vaccine from 3, 7, 14 and 28 days, and primary repair should be planned. It can be occult injury or an obvious, so high index of suspicion should always be considered, and the dictum goes that any lid laceration medial to the punctum should be suspected to be involving the canalicular system. If we have time, we can go into the details of the canalicular system repair. The proximal cut end is easy to find out, while the distal cut end is difficult. It can be localized, although one has to be very careful, especially the PG students, because they are the first to be exposed in the emergency areas. They should not fiddle out with the area of injury. The examination should be done in good illumination and under microscope. If you are able to find the distal cut end, it would be good for the patient, and we can pass a stent and do a pericanalicular suturing, and accordingly we can manage it. So a good managed wound will give a good picture, and not going into the details of the video. if the bell has already rung. So, success rate of canalicular repair is 20 to 100%, and it rises to a greater rise if it is a microscopic and done under good illumination and silicone intubation has been done. Delayed repair and dog bite injuries definitely have poor results. For prevention, for especially children, community, they should be educated about the risk of dog bites. One should be aware, and if you know that your area is being troubled by such, you should approach the local authorities to find out means of dealing with it, or else you should be protective on your own, especially the old, like people who have their old parents at home. They generally go for walks and they get involved in these things, children while playing. So you need to be aware of all these things. Healthcare providers should be educated about it, and health authorities and policy makers should ensure rabies control within dog populations. And with that I conclude. Thank you so much. So it's a big menace if we think of it, and we all should together work on it, and then only we can protect.
Thank you, Professor Chawla. You have touched upon a very important topic, because these days dog bite, protection of dog has become a community issue, isn't it? You have given some guidelines for the PGs, but I can tell you in our state scenario, most of the general ophthalmologists are scared of even touching the case of a dog bite. The moment it comes, they may do a little watch and say, go to Professor Maya Hada Jaipur. So but then what is your message for a general ophthalmologist if they come across a case of mild to moderate degree of dog bite, in the sense of periorbital cuts and all that?
Sir, ideally it should come from within. If you have that tendency of helping out the patient, a poor patient who has come, you will definitely work on it. And when you know that this patient is not going to give you any returns, truthfully they will send it to the medical college, isn't it? So it is your conscience that first of all, and the instructions are, as I've told you, sir, there are no controversies about the guidelines that have been laid down. So every general ophthalmologist should rather put in a like a fly or something in their hospital, and for the general
That's a wonderful idea.
yeah, for the general people also, and for the staff people also. So initial, at least as we have said, cleaning and not the debridement, washing of the area, and betadine cleaning, at least that basic primary part, till the patient even reaches to a center where if they are not capable, they don't have any oculoplasty surgeon or somebody to do the repair, at least this primary part can be done. So many times, sir, we have seen children coming to our OPD with hanging lids and like tissue loss, because they have just been referred like this. At least a primary bandaging sometimes in the traveling helps to protect that tissue loss that has occurred. I have seen in my own OPD like tissue loss, because वो दूर से गांव से आते हैं, they just rub it and all, and so much damage has been done. At least the primary control can be done, and obviously requesting the patient to take care of the vaccination protocol is very important.
Yeah.
And overall, the health providers or the municipal corporation has a very big role to play in this community menace, but we often find it's very difficult. I am living in a medical campus which is considered to be a very posh area of my city. Still, you won't believe, I cannot send my parents without a stick in their hand to go for a walk, because it's so dangerous. And it's not only the dogs, nowadays monkeys have become even a greater menace. So
Yes, very true, ma'am. One important point that I want to ask you, that regarding the timing of the repair, because many a times we come across patients who are left for completing their vaccination for 28 days, and then they are called upon for repair to for a safety of the surgeon maybe. So I think a primary repair should be advocated, and that should be the message
yes,
to everybody.
after cleaning the area with and instilling immunoglobulin, primary repair should definitely be done. Even though good apposition may be not there, even though you inside you know that secondary repair will be required, because sometimes so much tissue loss is there and you cannot approximate the area. But at least a loose suturing, if not at all, and primary repair is a must.
Primary repair has a good prognosis
Yes,
always,
definitely.
rather than in cicatrizing
Yeah.
condition. When the patient comes to you,
Yeah.
you cannot do
Definitely.
much for that. So that should be
And at
clear
that
for
time
all.
obviously you should try that the lacrimal drainage should get protected, but often if it, you know that it in the canal, but at least the apposition, the building of the medial canthus, basic things should be done.
Ma'am, one question regarding repair of the canalicular tear. Do you use these mini monocular stunts? How are the results?
Not in the primary repair of dog bite, I avoid unless and until it's a very clean wound, it appears that nothing is lagta nahi, but I prefer to do a simple suturing in the primary repair and later on going with the minimum.
Not and the, any difference, Professor Maya, can you highlight over it that should we, with the primary canalicular tear, proper approximation and putting monoca stent, I think the results with the primary one are much better,
Yes.
because if we if okay, if we wait for secondary implantation, maybe even we not able to go through the
Exactly.
stent. What's your opinion?
Yes, definitely, sir. The realignment of the epithelialized mucosal channel is important, and that should be done within 48 hours ideally. And then when you place a stent, then across that the epithelial lining will develop. And if you leave it for a few days, then the fibrosis will occur, and it's challenging to put a stent after that. So it's always advocated that whenever you do primary repair, you put the stent then and there. So if the patients of canalicular tear comes to us after a month, it's very difficult to dissect and find the distal cut end, and yeah, it's always preferable to do it.
Contraindicated, but we can.
Yes. So thank you so much, Dr. Urmil. And next we have Dr. John Sarkar with us, very prolific, dynamic corneal surgeon from Calcutta, and he'll be speaking on ultra-thin DSAC in the era of DMAC.
Thanks, Dr. Maya, for your kind words. First of all, I would like to thank ACOIN and Shamanta sir for giving me the opportunity. So I will start my presentation with some of the patients who refer to a cornea OPD with these clinical features, all having the profound visual impairment for corneal decompensation, but all the patients having the sound posterior segment. That's mean all the patients having the visual potential is there. So these are the special case scenario, and what new in the endothelial keratoplasty? Definitely the must answer is the keratoplasty, endothelial keratoplasty. What new? So next couple of minutes I'll be discussing the ultra-thin DSEC by my new tech in the era of DMEC. I have no financial interest. So the type of endothelial keratoplasty is that it may be the DSEC when the posterior part of the stroma approx 90 to 100 micron with the descent membrane endothelium is transplanted, or it may be the only the endothelium with the descent membrane transplant, that is the DMEC. So what is the ultra-thin DSEC? Ultra-thin DSEC, the thickness is very thin. While the conventional DSEC thickness is 150 to 50 micron, whereas the thin DSEC is approximately 100 to 149 micron, and ultra-thin DSEC, it's the thickness of the graft is 50 to 99 micron. So it's in between the 50 to 100 micron. And nanothin, it's near about the DMEC, or it's approximately 15 to 49 micron. So I'm just showing the video how we can modify the normal DSEC. Manually we can do the ultra-thin DSECs. So here we are just in artificial anterior chamber. We are using the approximately 400 micron diamond knife customized. It's not very much expensive. Then starting the dissection with normal SIS crescent, which approximately 400 micron, just like SIS tunnel from one limbus to another limbus. Once I get the plane, then we are using one customized instrument by spatula, across 15 degree lamellar dissection. This is unedited video. We can make it this much that speed. So once it has been done, just for paucity of time, I am just first forward the video. We can cut the first 400 micron. Initially we used to check the thickness by the on table pachymetry, but once we have done more than at least 100 cases, then we can predict. Now we are starting among this basis customized 90 micron resin and second round of dissection. Definitely there is a chance of perforation is there, but Once you become accustomed, your hand become the steady, you can do it very easily. And those who are doing the exercises regularly, it's very easy to do, accustom this technique. And so it has been done. Now the corneal thickness barely below the 100 micron. And now we are inserting the graft, partly from the AC with the air, and because the graft behave like a demi graft, that tends to be curled up, and we unfold the graft and from the AC with the air, then followed by centralization of the graft and complete the surgery. I'm just moving to the second case. I'm not going to the same thing in the second cases. Just first forward the thing. Here we cut the thing, done the dissection, lamellar 1. We cut the thing, first round, the second round dissection started, and here the graft is so thin, it is very difficult to, so I'm just by needle insertion inserting the graft and unfold the graft and from the AC with the air, and the graft too looks like a demi graft. So outcome, this is the outcome of the patient. So graft, you can see the graft thickness in A is supposed to 44 micron, and this is the post-operative specular count with 1144, and this patient maintained the 6/9 vision over the last 4 years follow-up. This is another patient, one-eyed patient. You can see the other eye, no peel. We have done the ultra-thin dissect for this patient, graft thickness 85 micron, and the patient having the 6/6 vision for 6/9, 6/12, and just any without a cylinder unaided vision. So patient very much happy and maintained this vision for last 3-4 years. So what is the when we compare we have done one eye demic, another eye dissect, but both the eye almost looks like a behave like same. So definitely if your surgical expertise is better, so why we can do the ultra-thin dissect whenever you have a shortage of tissue, because in the demic having the different learning curve is there, always we need a backup tissue. Specifically if you are working in a private setup, purchasing the backup tissue is really tough. In that scenario, one from if you are customized this technique, you can give the same outcome as the demic. So here actually the one patient having the post done by the post demic graft, and we have done the 360 pass is there. So purposefully we don't want to, this patient the visibility as poor, the demic is really difficult. So we have done the ultra-thin dissect for this patient. I am not going the same repetition. You can see the visibility is very poor. We have done the same the ultra-thin dissect for this one-eyed patient from the Bangladesh who used to come in wheelchair pre-operatively, and this is the post-operative picture of the same patient. And now he is very at least 6/36 vision due to the glaucomatous cupping, but at least maintain this vision for good ambulatory vision. So this is the practical implementation of the using the ultra-thin dissect in the demic. So what is the outcome? Outcome in the form of BCVA, surface question, cornea clear, and the happiness question of the patient. So these are the relevant studies which compare the ultra-thin dissect is comparable to the outcome of the ultra-thin, the demic. Whenever you have a shortage of tissue, whenever you don't have the backup tissue, or you can plan for the ultra-thin, you can accustom the technique of the ultra-thin dissect in place of the demic. Definitely both are comparable and reproducible. We have done some of the study that showing this outcome is, I'm not going for in details for the paucity of time. They're showing this almost outcome is same. Rather, we need some rebubbling in case of the ultra-thin demic rather than ultra-thin dissect. We no need for the rebubbling, or almost outcome is satisfactory. So my technical messages are that the endothelial keratoplasty provides a significant safety and the functional advantage over the PK for the eyes with endothelial dysfunction. Visual outcome seems after the introduction of the automated microkeratom, though the demic is upcoming technique, but ultra-thin dissect is equally good if can be done correctly, specifically wherever you have no standby or backup tissue. And manual dissection in ultra-thin dissect is the least expensive. You no need for the microkeratom, and then you have the elastic machine investment, may be more appropriate for the procedure in Indian scenario. Thank you very much for your patience sharing. These are some of the patient who has the first slide I am showing. This is the outcome of those patients with ultra-thin dissect. Thank you. Thanks for the Shamanta sir for giving me the opportunity. I'm really thankful to my fellowship mentor, the chair of cornea, Dr. Prema, for giving my hands-on training, my overseas mentors. Thank you very much. Thanks my present working place.
What is the advantage of ultra thin DSEC over conventional DSEC? And what cases you will choose for this particular procedure?
Sir, ultra-thin DESEC now, most of the cases we switch over to the ultra-thin. In my all the cases, DESEC cases, whenever I'm not doing the DEMEC, if I do the endothelial keratoma 10 patient, suppose, so almost if the visibility is good, my first choice would be the DEMEC. Now I don't need for the backup tissue after doing almost a good number of the cases. But during whenever we have the learning phase or we have even also we have a doubt that we may be landed up with the because there is a tissue preparation we are I mean dealing with only the 18 micron Descemet's membrane. There is a high chance of preparation of it unfolding or your if the ACIOL is there and there is a suppose a pass is there. In that scenario, definitely DEMEC is not a, or the visibility is poor because then if the graft is revert, then the entire whole game will be changed. So in that scenario, the ultra thin DESEC is a much more predictable. And nowadays, we usually switch over to the ultra thin DESEC most of the cases, and that is manually prepared. We are not using the microkeratome because microkeratome, if you have the microkeratome, but the problem is each time if you are using the blades, the blade itself causes 25 to 20,000. So it add on the cost of your endothelium. And most of the patients, those who are referred to us, coming to us, because they are in some of the where they are referred by the primary surgeon, and definitely this is cost effective. We have to keep in mind too also.
I thought ultra thin DSEC would maintain better corneal configuration post-operative so that there is minimal astigmatism compared to conventional DSEC.
Usually,
and number two, what do you do if there is perforation during the procedure? How do you modify your surgical approach?
Touch wood, sir, I don't have the perforation during my
In theory,
ultra thin.
for the sake of the audience.
Yeah. For the first of all, I'll just answer one by one, sir. In case of DESEC, actually, as we are not putting the suture in corner, whatever the wound we are doing the suture, that suture remove. Just like SI says, to maintain the air tamponade, we are giving the suture. That suture we can remove after 1 month. So it will not encounter in the most of the DESEC or ultra thin DESEC and DEMEC patient having a no cylinder like the PK patient. Right. And the visual recovery very good. Usually the ultra thin DESEC, what they cause, there is a hyperopic shift. As you add on some of the tissue, so there is a hyperopic shift of the patients. So that is actually, there is spherical power is added. That's why whenever we do the combined procedure in case of the Fuchs endothelial dystrophy or other corneal decompensation, when we plan for the IOL along with the phaco IOL plus the DESEC or DEMEC, then we actually make the patient little bit of myope. Because under we more right. 1 minus 1 or 1 ideally 1 to 1.5 myope because you are adding some of the tissue, and definitely it is not for the thickness because they maintain that I mean they are not encounter for the your astigmatic part. And if there is a perforation is there, traditional teaching is there, definitely always learning phase in institutional basis whenever we are fellow or I mean whenever we are working with institution, always we just start our DESEC first case and back up or 2 to 3 cases. Suppose I have a 4 transplantation or first we series or we started with the lamellar keratoplasty. Sometimes if you need the thing, then we can we utilize the tissue. But sometimes, but in private practice or if you are working in a somewhere you have to purchase the tissue, then it is very difficult to you have to book the 2 tissues. So initially whenever we are learning phase or post learning phase, we usually clubbed up the 2 to 3 cases together. Suppose we call the patient next day another patient, and then if it is not utilized, then that it should utilize in the PQ or the second another patient. And in on table if there is a perforation is there, just like that you have a suppose premature entry in the SIS tunnel. So we stop here, you can put a suture over there and we can go to the move on the other part because it's the artificial anterior chamber we are doing the dissection. We switch over to the other part and start that part we scaffold the tissue. And we can eccentrically because we need a healthy endothelium. So we can eccentrically we can punch the cornea because it's approximately we are doing the dissection the 12 millimeter approximately from one limbus to another limbus, and we need approximately only 7.5 to 8 mm healthy endothelium.
Thanks, Dr. John. I think we have overshot our
Thank
time.
you very much. Thank you very much, sir. Thank
Let's
you.
conclude the session now. Thank you.
As Professor Kavita Bhatnagar is not there, I request Professor Maya Hada for her concluding address.
Okay, we have Dr. Okay, Dr. Vidya Bhushan is here. Sorry, yeah. So, so I request Dr. Vidya Bhushan to be here, yeah, for his talk on ocular anaphylaxis management and clinical outcome after corneal bee sting.
Good afternoon, and thanks to Professor Samantha sir for giving me for opportunity here. I am going to present this one because of a lot of cases coming from the village area to the Regional Institute of Ophthalmology with bee sting, and some cases is coming with late stages. So just have 3 or 4 cases here. I summarize here. Case 1 is 4 years old female child referred to us with the complaint of swelling, increased lacrimation, pain, and not able to open her left eye for past 5 days. This episode had occurred after some of bees attack her all over her body, as told by her parents, and on gross torchlight examination, upper and lower eyelid were mild edematous, conjunctival chemosis, and corneal edema was present in her left eyes. Patient was not cooperative for slit lamp examination and fundus examination, so planned for examination the GA. Next day, ultrasound B scan was normal. ASOCT shows corneal edema with bullae. Intraoperative B find out that reveal a foreign body like bee stinger embedded in the deep in the stroma of the cornea temporarily at 3 o'clock position and 2 mm from the limbus in her left eye, infiltrate around the bee sting and generalized corneal edema that may be due to the toxic and immunogenic response. Anterior chamber details was hazy, but another foreign body was seen in which was stuck in the iris, and there was heterochromia iridis, pupil pharmacologically dilated, and lens was clear. So 2 foreign body was noted. Both foreign body was removed and sent for the HP microbiology, which shows the bee stinger. Post-operative oral steroid 1 milligram per kg body weight was started. Oral antihistaminic continue, and topical antibiotic lubricating eye drop, cycloplegic eye drop continued. Topical steroid eye drop added 3rd day post-operative. 1 week later, stromal edema resolved completely, although small opacity at the site of bee sting remained. Child is able to open her eye comfortably. Vision improved significantly to BCVA 636. Anterior chamber was quiet and patient was registered for the optical PK. Case 2 is a 46-year-old male with a history of honeybee attack at his right eye. Bee sting was removed immediately in OT, and medical management started post-op follow-up 3 months. All symptom was subsided, but vision didn't improve significantly. It was 6/60 only due to corneal opacity with neovascularization and cataractous lenses. So this is the pre-operative picture and as a 3-month follow-up picture for same patient. Patient planned for the optical PK there after phacoemulsification and PCIOL. Post-operative BCVA was 6 part came after optical PK. Case 3 similar case with 2 corneal opacity developed later and planned for the optical PK. Another case 4 young male presented with the 3rd day of sting injury with complete stromal lysis, melted cornea with perforation planned directly for therapeutic PK. Inflammatory membrane was present in anterior chamber and all over the lens, removed and was throughoutly started steroid oral and topical from very first day of surgery. So discussion is here. Corneal bee sting have been rarely described in the literature that can lead to the potentially devastating complication like ocular anaphylaxis, keratitis, severe toxic endothylitis, bullous keratopathy, and corneal opacity. Toxic uveitis, iris atrophy, and lenticular changes can be occur. Secondary glaucoma, optic neuropathy, and even phthisis will occurs. Treatment is usually aimed to minimize the toxic immunologic response. However, due to the rarity of the injury, there is no established clinical guideline for the management of this patient. Early surgical intervention, which include removal of bee sting and high dose of steroid, along with the topical antibiotic, steroid, and cycloplegic, is mainstay of treatment. Take-home message is prompt and early intervention with the removal of bee sting, oral steroid. Almost all patients need keratoplasty surgery due to severe inflammation and further corneal opacity. Thank you.
For your good presentation. It holds a lot of importance in the day-to-day practice. Thank you. With the permission of our President, sir, I request Professor Maya Hada for her concluding address.
Okay. Thank you. Okay.
Sir.
one comment on Dr. Vidyabhushan's talk. Usually what we see in bee stings is that because of the blink reflex, there is a sting on the lid and we get this periorbital cellulitis like picture. But the direct sting onto the cornea is extremely rare, and we should know this condition. All the ophthalmologists should be aware that it can lead to blindness because of the corneal opacity and severe inflammation that it causes. So very important point that you have put forward. And immediately the stinger should be removed, and high steroids topically as well as oral systemically should be administered to control that inflammation. So thank you for that. So we had this ACOIN session in AIOS 2026 with our esteemed chairpersons, Dr. Awad Dubey sir, past president of ACOIN, Professor L.K. Nepalia sir, Dr. Tejinder Singh Aluwalia sir, Professor Tariq Qureshi sir, and our the most dynamic person of ACOIN, Samantha Dada sir. So by thanking everyone, I conclude this session, and I'm thankful to all the speakers, chairpersons, and all the audience for being here with us and their patient hearing. Thank you very much.
Because good program.
Yeah, we call upon all the chairpersons and Dr. Professor Dada for a group photograph. Yeah, please, audience and the speakers, you are requested to join us for the photograph. Dr. John, Dr. Vidya Bhushan, yeah, please come.